Вітаю, шановні колеги. Мене звуть Андрій Varvinskiy, я працюю анестезіологом на південному заході Великобританії та у Лондоні. Сьогодні ми домовилися з організаторами, що я виступлю англійською мовою. These are my declarations of possible conflicts of interest. I do get paid for occasional presentations, and I get royalties for my book, How to Pass the EDAIC. So any of you who are planning to sit the part 1 or part 2 of the EDAIC will benefit from having this book. Let's talk about my topic today, about the aging anesthesiologist and what are the problems that we are facing today in the society as doctors. We have enormous responsibility for the patient's life, for the patient's well-being that we are holding in our hands when we are anesthetizing them. We usually work long and antisocial hours, evenings, nights, weekends. We are dealing with more and more aging and obese population. The recent opioid crisis in the world, you probably remember that at some point in the past, WHO wanted to withdraw ketamine from the circulation worldwide, and I remember signing the petition myself, because without this important drug, the whole anesthesia in the world will collapse. There is shortages of drugs. I've recently learned that United Kingdom, where I work, does not produce its own insulin, and we have to buy it from abroad. So in the current state of the world, this could be a massive problem. And there are many ethical issues of many kinds between the countries, and the world is at a massive war at the moment. These are big problems, but there are even bigger problems that I would like to address today, and they are lack of hospital beds, at least in England. We only have 2.5 per 8,000 population against average of 4.7 beds per 8,000 population across the world. We have to manage the allied professions, namely surgeons and other allied professions, which could be not easy to manage. We are facing, I don't know about you, but we are facing a massive challenge with electronic patient records and electronic anesthetic charts, which allegedly will supposed to be helping us to increase the productivity, but it's not the case. And for several years, the trusts that are introducing electronic patient records are actually dropping productivity. However, the massive crisis is the workforce crisis everywhere in the world, and aging of anesthetists is an enormous problem. Let's talk about those in details. This is from the national audit, NAP7 audit, that's been published in 2023, and you can see in red different population groups are increasing. And if you can see that from the age of 55, all the groups are increasing, 0.7%, 1.4%, 0.5%, they're all increasing. So the population is getting older and older. And this is the trend, and the trend is the top line is patients of 50 to 64 years of age, and population and patients, and 15 and 24 age is actually decreasing. So the population worldwide is getting older and older and older in any type of society. At the same time, the BMI is increasing. On the left side is the BMI on the increase. Above 25, above 30, above 35, all an increase. In the adult non-obstetric population, it's even more problematic. In obstetric population, BMI is increasing. So we're dealing with elder and less healthy population as such. At the same time, we're having a problem, and this is due to the workforce crisis. You can see this is the total NHS waiting list for consultant-less elective care. So people are waiting and waiting and waiting, And at the moment, it's 7.7 million patients in the UK waiting for the treatment. In England, existing workforce is not coping with the amount of elective work that needs doing. And the first line is the start of the pandemic, and you can see how it increased first, then it dropped, and then it went up again. And then the second line is the start of the industrial action, because doctors in the UK went on strike due to their salary not being increased since 2008. So essentially, since 2008, we were not paid according to index that is should have been applied due to inflation. So in fact, since 2008, our salary dropped by about 40%. This is the article that has been published after the Sir Robert Mackintosh lecture delivered by Francis Clerk in 2014, where he predicted increasing the number of population, increasing the number of anesthetics, this is in red, but decreasing the number of anesthetists, this is in green. And you can see that the number of anesthetics that need to be given is going up because the population is increasing, but the number of anesthetists that have to provide this service is not increasing at the same time. And that's what actually happened. What about globally? So globally, UK, on the right side here, we have, this is the Anaesthetic Workforce UK State of a National Report in 2024. And this showed that the UK has 14.23 anaesthetists per 100,000 of population. This means it's lagging behind other large, high-income European nations such as Germany, 37.37, Italy, France, and even many low-income European countries like Moldova. Overall, UK anaesthetists per 100,000 levels are 26 in Europe and 34th in the world. I'm not sure about numbers in the Ukraine, but in Belarus it's 25.6. So Belarus is better off compared to United Kingdom in the sense of how many anesthetists are there per 100,000 inhabitants. This could be due to the fact that people are leaving Belarus, but flocking into the UK. The UK census of 2020 shown a shortage of 1,400 NHS anaesthetists already, which meant 1 million surgical procedures are delayed per year. In 2024, another document called the Anaesthetic Workforce UK State of the National Report showed that although numbers of anaesthetist grades in the UK rose from just over 10,149 to 10,628 in 2022, the demand had increased further. So the number are 15% lower than what is required, with a shortfall of around 1,900 anaesthetists across the United Kingdom. We are roughly 70 million nation. And the current shortage means that 1.4 million operations and procedures will be not done, but delayed every year. And why is it so? Why is it because of the anaesthetists? And we are the largest specialty. In every hospital you look at, we are the largest specialty. Because we do many things, not just giving the anesthesia, we're involved in radiology and perioperative care services, we're involved in pain services. At least in the UK, it's the anaesthetists that provide the chronic pain services and, of course, acute pain services. We're involved in emergency hospital transfers, in labor ward, and in many specialties. So there is a overall everlasting increasing demand in the number of anaesthetists that are required in any medical institution. So this particular report found interesting things about career intentions. So 1 in 4, 25% of consultants, and 1 in 5, 20% of specialists, anaesthetists who are not consultants, are planning to leave the NHS within the next 5 years. Planning to leave NHS doesn't mean that they're not going to work in other hospitals at all. They may move to private practice. But in the UK, private practice only constitutes about 15%. And around 1/3 of the anaesthetic workforce may be working less than full-time within the next 5 years. So people are tired. People would like to reduce their working hours. So around 1/3 of respondents said that COVID-19 in particular made them less inclined to stay working in the NHS. That was a hard time for lots of us in the UK. At least, well, and around the world, people worked really, really hard, and lots retired during or straight after the COVID because they could. So why do anaesthetists in general retire or leave early? Lots of us are not feeling valued or supported as doctors. There are concerns about taxes. Not sure how it is in the Ukraine, but we are facing a very high taxation up to 45%, and also pensions. People are worried how they're going to live in terms of will they be able to afford to live on the pension. Bureaucracy, leadership issues. In my hospital, in the last few years, the management changed several times. Not being adequate for the job, mental well-being, reducing stress. People are feeling burnt out. People are feeling really, really tired. Workload on call is high, particularly when you're in training. When I started anesthetic training, I was doing 1 in 3 on calls, literally 10, 11 nights per month. We were working pretty hard. And when I started as a consultant, we were working 1 in 12 nights. It's less so now. Lack of flexibility, lack of autonomy, lack of respect. People think that we are not a real doctor sometimes. They just openly ask that question. Sometimes they have a feeling that we are the guys who paid a lot of money for putting people off to sleep. People don't know what we do. They think you've injected something and you go and read the paper in the coffee room. You are just an anesthesiologist, some people say. People are not aware that we are even the doctors. So for some people, this comes as a shock, as a surprise, and they want to leave a specialty altogether. In 2022, this guidelines has been delivered by the Association of Anaesthetists and published, called Age and Anaesthetist Considerations for Individual Anaesthetists and Workforce Planning. So basically, they analyze what's going on with the nation, what's going on with the doctors, and particularly anaesthetists, and what to do to retain them, because we have to retain them, otherwise nobody will be able to do any procedures. So in 2022, 45.4% of anaesthetists were over age of 50. So almost half are elderly. Well, not elderly, but oldish anaesthetists. The anaesthetist intensivist workforce is aging. GMC data show that the percentage of licensed anesthetic and intensivist consultants age over 60 has risen from 8.2 in 2014 to 11.9 in 2022. And that the percentage of 50 to 59 risen from 28.4 to 33%. This likely partly explains why retirement levels have increased and poses a challenge for the future. Although not all of the anaesthetists in the aforementioned age groups are set to retire immediately, they are likely to do so or within the next 5 or 10 years. That has the potential to increase the anaesthetic workforce gap even further. What's going on when you're getting older? After about the age of 60, the processing of information speed decreases. People start losing short-term memory, the ability to retain new information. Your vigilance declines, so you cannot work in a stressful environments like anesthetic or intensive care for a long period of time. So performance may therefore become more variable in older anaesthetists. There are age-related physical health problems. The incidence of chronic conditions, if you had musculoskeletal problems, cataracts, or acute illnesses like ischemic heart disease, also on the incline. Tiredness influences older doctors' performance and mood. They can become snappy, angry, or whatever. The quality of sleep worsens with age and sleep becomes shorter. So traditionally in the UK, people worked very hard in every specialties, and when it was in medical, in the NHS, you could retire well, I still could retire at 60. Now it's not possible. When it's 60 came, the majority of people took the retirement. However, it now has been increased, so everyone has to work until 67. Are all the anaesthetists actually valuable for the department? If what I've said is happening, so why would you retain somebody who is slower, who is less sharp, and so on? Actually, we are, those who are older, we're cool head guys. We've got years of experience. We became experts in some fields where we've been working, particularly if you develop an interest in, like myself, develop an interest in head and neck anesthesia, in difficult airway, in regional anesthesia, then you become an expert. You're confident in what you're doing. You've seen it, you've done it, you've got a t-shirt. You made mistakes and you learned from those mistakes. You know what is going to happen if you do A, what will be the B, if you do C, what will be the D. You have lots of horizontal connections within the hospital. You know other specialties. You've worked with this surgeon, with other surgeon, and you know who is good and who will you call in a really difficult situation. And what will be your decision to actually continue to work or retire or partially retire and return? In the UK, it's now been introduced some of the scheme called Retire and Return. So this decision is influenced by many factors. Obviously, your personal health. So it's important to stay fit. The job satisfaction being valued. Working hours. If there's long working hours, you are less inclined to stay. Your financial status and your pension arrangements, if you made financial arrangements, if you've been investing in not in just NHS pension but in a private pension, then you may say, okay, I have enough finance, so going to work. I'm not actually going to work to earn money. I'm going to work to help patients and earn a little bit of money. Obviously, your family commitments, your peer retirement norms. So if everyone is retiring at 60, you think, I want to be like everybody else. But if everyone else is staying longer, you say, okay, this is the new norm now, and I will follow the new norm. People are likely to behave like other people, particularly if you respect your some other colleagues of yours who've done exactly the same. And the attitude of the employer. Employers in the UK in the past, when you reach the retirement age, were pretty strict. They will re-employ you, but on a 12-month basis. Now they don't have this luxury, and then will re-employ you indefinitely as long as you come and work for whatever hours you can offer to the trust. So how to keep the anaesthetist going? You can reduce the on-call hours or even stop offering the on-call hours at all. You've been able to adjust clinical practice to the environment with age, so do not ask elderly anesthetists to get involved in the long operations, in operations where it's too hard. Give them lighter, easier lists to do. Contract flexibility, being able to work flexibly less than full time. So if the anaesthetist comes back and says, I would like to work, but I would like to work only 60% of the normal time, it's fine. They will be well rested and come back maybe every other day or something like that. Whatever that anaesthetist or other doctor of other specialties offering to the trust is good for them to take. So how the departments themselves, because in at least in my hospital, it's the department that decides how to re-employ after the anaesthetist has retired and returned. So we decided that after 55, you have a chance to come off the on-call rota. Don't do nights. So instead of that, between 55 and 60, we offer the department a Saturday or Sunday trauma list instead, but during the daytime, not at nighttime, because your cognitive function as an aging anesthetist is deteriorating at night, and your decision-making is deteriorating. We do job share. For example, when I'm at work, my job share person is not. And then when he or she is at work, I am not. No weekends, which is important. Annualized contract is a very interesting concept. This is where department says, okay, you're going to deliver so many days, so many lists, operating lists per year, and you can deliver them at whatever at whatever schedule you like. You can deliver them in 6 months and then have 6 months off, or you can deliver them at 1 month at the time, have months off, or whatever other way. So I work this so-called 6 weeks on, 6 weeks off pattern, where I work for 6 weeks, 3 days a week clinically, and then I'm 6 weeks off. And then during those 6 weeks, I can do whatever I like, do private practice, or deliver a lecture for you like this, or have a project in another country, or just enjoy my time traveling, and so on. Give those anaesthetists familiar lists for that individual. Don't isolate them. Don't send them to like remote areas on their own. They may need some support of a junior anaesthetist. There is a document, Welfare for Anaesthetists Special Interest Group, that also gave advice on continual professional development for all the colleagues, which says join the colleague to remind yourself of other expertise market working. So join them on the list, learn from their experience, maintain your commitment to teaching of junior colleagues, and allow them to teach you at the same time, because they have lots of experience. Maintain and update your base active CPD activities. Attend regular morbidity mortality. Pacing your career strategy is important. Retire into something, not from something. So don't like stop abruptly. Retire into a hobby of some sort that you might develop, whichever that will be: skiing, running, swimming, whatever. Keep fit. Keep professional activities going. We have this fantastic doctor's updates which we go to, which is to do with lectures in the morning, skiing in the afternoon, and then lectures in the evening, which maintains a perfect balance of work and play. Plan for later life events, meaning plan how you're going to retire and what you're going to leave on when you retire. Other career possibilities might include medical education, professional bodies, preoperative assessment clinics, medical legal work, management, government's committee, research, private practice, projects with colleagues in other countries, and humanitarian work. This is a little video.
От нашего коллектива импровизированного, скажем так, спасибо огромное количество израильских бандажей, как турникетов, хирургические наборы, которые сегодня уже уезжают в полевые госпитали. Большое количество довольно, множество назофарингеальных духоводов. Тоже ребята очень просят. Сегодня половина выйдет точно, а вторая половина, я думаю, к концу недели разъедется. Все пойдет на дело. 1000 раз благодарны. Все у нас собирается из ваших коллег, собираем аптечки, ребятам помогаем. Очень надеемся, что минимально будет это нужно, но так или иначе тоже когда оно есть. Благодаря вам мы можем это укомплектовать. Спасибо большое. Спасибо большое.
This is something that I've been involved since the beginning of the war in Ukraine, and I'm still pursuing this and helping different hospitals. That was the hospital from Dnipro. In conclusion, what I would like to say is if you live longer, you need to work longer. Anaesthetists are getting older. It is important to retain the anaesthetist, stay physically fit. That doesn't just perfuse your legs and arms, also perfuses your brain. So if you stay fit, you will be thinking better. Pacing your career is important. Do not, LTFT means less than full-time employment. It offers better work lifestyle, and reinvent yourself every 7 years. Get something new, learn some new language. Keep going, and again I offer you a chance to look at my website, my YouTube channel, where you will find lots and lots of educational activities. If you want to ask me questions, this is my NHS email on the screen. Thank you very much. Дякую за увагу.